excited and pleased to announce that he is going to speak with us, Mr. Nikhil Krishnan.
Sweet. Awesome. All right. Can you hear me? Okay. I was told to put a lot of memes in this deck, which I feel like is the opposite of a Thelma and Louise reference, but we're gonna see what we can do. So when we were brainstorming what to do this talk on with the various permutations of people named John that are organizing this conference, we landed on what we call small signals, big shift. But what I really wanted to call this is what are the weirdos in healthcare doing today? And really what this talk is going to be about is what are some of the really strange pockets of people doing in healthcare today that might actually become normal in the future. I mean, a lot of people here today are doing things that many people would probably consider weird pockets of healthcare, and we're trying to do a better job of making it normal, right? So I'm here to talk about some of the strange things that people are doing today. We kind of already went over this, but I write a newsletter. It's popular for reasons I don't quite understand either, but I try to go down strange rabbit holes in healthcare and things that I find interesting. So, next week is about HIPAA and how pixel tracking works in Facebook direct-to-consumer ads. If you're into shit like that, that's kind of what we talk about. Okay, so I want to basically start this by saying that I spend a lot of time on the internet, and I spend a lot of time with entrepreneurs who are doing stuff in weird slices of the world. And so, unfortunately, I've seen things that I wish I hadn't seen. But now you have to know some of these things too. Today, I will be your Sherpa into the more, I would say, relevant parts of the healthcare universe and the online forums for you all today. So I want to talk a little bit about, this is very sensitive. Like me. Okay, so I want to talk a little bit about kicking things off with something that's probably very relevant to this room, which is what I like to call the gray area of medicine. So basically, this is anything that exists between total snake oil and in full practice care guidelines, right? There's a lot of stuff in the middle here that are actually probably useful, but there's kind of a high level of noise to signal that happens. And so what's happening today is that a lot of people want to consume more of the stuff in the gray area of medicine, basically, right? They feel like the traditional healthcare system is holding things back from them. They feel like, especially if you have money, you should be able to throw money at healthcare problems and get more stuff out of it, right? And they want to have more agency in their decisions, right? It's not great when you kind of go to your primary care physician, they're like, yeah, just rest and drink fluids. And you're like, there's probably something I can do here, right? And then on top of that, the lag between what shows up in research and what actually gets covered by payers is growing timeline-wise, right? The quote I always hear is 10 to 15 years between something that shows up interesting in research to when it's actually covered by a payer. So the thing is that, again, in that spectrum of stuff that's total snake oil to actually interesting in actually covered by payers and care guidelines, people want to kind of explore that area, but they're looking for people to help them do so. And a lot of the rise of longevity medicine, concierge medicine, I'm sure you're going to love the direct primary care docs in this room. We heard a little bit, for example, about titration and compounded GLP-1s. A lot of this area where it's okay, it's probably useful and helpful, but me as a regular consumer, I'm not good at shopping around this area. I need a guide to do it. And so there's a lot of people who want to pay cash because they know their payers won't cover it, but they want to explore this gray area of medicine. And then the other part of this is that a lot of this stuff is getting more popular with social media, right? We talked a little bit about that with the GLP-1 stuff earlier today. People are becoming more aware of the research, which is another part of it, right? It gets shared across. They're like, hey, I've heard of this thing. I saw this in some LinkedIn post, blah, 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 whatever. They see, Kim Kardashian doing a full body MRI and, they're trying to understand, should they be doing it? So you start seeing social media spread a lot of these ideas, and people are asking hey, is this a thing that is right for me or not? Just some other examples that I think are sort of very popular today, hormones and peptides. If any of you have heard of TRT or the really strange stuff that the bodybuilder subreddits talk about, they go through some weird stuff. Then you have the lab testing, right? So for example, APA-B is a great example of something that seems to actually be quite useful for certain subcohorts of patients, but is still not totally a part of mainstream care. And so now there's a lot of people filling that gap with cash pay versions of it, for example, or even functional medicine tests. And then the last is embryo screening. So instead of doing single gene screening where you try to test for specific mutations, looking at polygenic risk scores to see, hey, which gene groups might associate with certain traits, for example, like predispositions for heart disease, et cetera, down the road. So all of this is in like cash pay land. There's like some research that seems to say it works or not, but people want to consume more of it. Okay, related to labs, an interesting sort of trend is people posting their lab results on social media. And I think there's a few reasons for this. One is that labs basically can kind of act as like a bat signal into the universe to find other patients that might have gone through some similar journey as you, right? I think this is also particularly true because now that labs are auto-released to patients, they are seeing it before their doc sees it and can help them with the interpretation. So, you see something's out of range, you start scrambling, you post it online, you're like, am I dying? Like, do I need to speed this up? Blah, blah, blah. People basically are using social media to post their labs and try to get answers more quickly from other patients that are similar to them. Or if they can't afford a lot of the follow-up things they need, can they give advice on what they should do instead? On the other end of the spectrum, you have people who are very healthy, posting their lab results as a way to flex on other people. Totally different cohort of people, but kind of same end result. So I am in my mid-30s now, which means I am in the South Asian male cohort of maybe going to be on a statin soon. So this has become a regular part of talking to my friends. But it is actually like a relatively normalized sort of experience, right? And if you want to find out like, hey, this happened to you too, it's a nice way to go to your own friends and talk about it and see what they did, right? But not everyone has that ability. And so what a lot of people will do is, again, they will go online and post this stuff. So for example, some apps have leaderboards that will show you how your labs are compared to other people in your cohort. Again, you don't all have to agree with it. I don't do this stuff either, but just know it exists. The second is that people will post their abnormal lab values online and say like, hey, I'm young, something's wrong with me, can you please help? Or like, hey, I was told I have to do this, I can't afford the meds, does anyone have natural remedies, blah, blah, blah. Or this guy who's like a, extreme athlete that just open sourced all of his biomarkers in an Excel sheet, and you kind of can just follow this guy's biomarkers if you really want to for some reason. So you had the whole gamut here. And then if any of you follow Brian Johnson or Don't Die or his whole thing, like he really takes it to the utmost extreme and is kind of posting a little too much about himself that maybe we should know, but he started this whole movement of people posting their own biomarkers online to talk about it. Okay, another weird trend, paid friends as a service. So basically people that are paying for companionship either directly or indirectly through some other service that they are getting that bundles this into it. So we'll talk a little bit about it. Why is this happening? A few reasons. One, on the clinical side, peers are actually one of the most inexpensive parts of a care model you can have, right? It's much easier to get a peer than it is to get clinical laborer, nurse, doc, et cetera. They can have more touch points with the patients, et cetera. And then on top of that, because there is a large loneliness epidemic in the US, it is actually an excellent patient engagement strategy. So a way to actually get patients to respond to what you need to do is by having a trusted person with them. And so, I don't have to probably tell you all this, but there is a loneliness epidemic in the US, and there are worse health outcomes as a result, right? You have higher risk of heart disease, of chronic conditions, way less likely to stay adherent to your medications. So as people search for companionship or solve the loneliness epidemic, healthcare institutions are actually one of the institutions that can benefit from this from an ROI perspective. And so you see this kind of show up. So for example, you have companies like Papa that partner with Medicare Advantage plans to basically send people to the homes of people on their Medicare Advantage plan to do things like help with daily tasks, but also just provide companionship and be there for the person. Firsthand is a company that uses patients with severe mental illness to basically be peers in the care model with other people with severe mental illness, again, to establish trust which is a big part of getting them onto, for example, medication regimen, et cetera. Or there are companies that provide sort of crash, I would say, courses or cohorts to try and solve specific issues. So, for example, like pain reprocessing therapy, for example, where you're doing it with a bunch of other patients. They are basically your peers through that journey, kind of bonding with them through that whole process. Now, this didn't really work. I guess custom animations don't work, but there are a bunch of companies now that basically provide friends as a service, AI friends as a service. So you pay, and there's basically a friend there that you can talk to. There's a lot of, I would say, ethical gray areas in this one especially, but a lot of people are using ChatGPT as their personal companion. I think, this is where I sort of, feel old in tech. But a lot of people are using that, and so that is another way that people are paying for a form of companionship. Okay, so let's talk about the next thing, which are physician apps and app stores. So again, probably not surprised. How many of you have heard a doc talk about how much they love their tools? They love Epic. I don't think anyone's ever said that. So physicians don't love the tools that they use, and then at the same time, the tools to create your own tools have gotten much, much easier to use. And so what you see is, have any of you used like Replit or any of these companies that let you kind of like spin up an app really quickly? Basically, these are companies that you just type in like, hey, I want an app that does this thing, and it'll actually create it for you. Just to illustrate that point, in about an hour, I made an app that is a text-based journey where you are in a medieval setting trying to get a prior authorization. And you can play it. It's a real game. I did that in about an hour. So today, you just kind of talk to the applications, and it gets made for you. Now, again, these are not like state-of-the-art applications. This is something called vibe coding, basically. So this is where you're talking to a conversational agent, and it kind of builds alongside you, but you do not need technical expertise. So again, is it best-in-class security practices? No. Is it meant for like wide-scale adoption? No. But it is perfect for like if you just want to build an app for yourself, your practice, et cetera, that is not meant to be distributed widely. And so there's a bunch of physicians now who are posting their own versions of their apps online. So this is a doc that basically created his own patient intake form that's multimodal, and so has patients actually go through a bunch of exercises to see where they feel pain on their body, and incorporates that into the patient intake flow. And he made it himself in Google Studio in probably like a few days. So you could build your own tools yourself. And I think when physicians build their own tools, a few things happen. One, they build for much more niche workflows that like affect them personally, that like general service providers have not been able to solve. And then on top of that, it gives some credibility to adoption for other physicians. And so that's why at the same time, you're starting to see these app stores that will sort of distribute these physician-created apps to other physicians, give a revenue share to the physicians that make them, either embed it into the programmable EHRs themselves, or let you build your own kind of agents that you can basically then resell. So some interesting stuff. Okay, so medical tourism for curative therapies. We've talked a lot about insourcing drugs from other countries as one example of ways you can reduce costs. So the other part of this, though, is that certain drugs and certain interventions are only available in other countries or certain states, et cetera, and also the way things are reimbursed in different countries are very different. So there's now become this kind of like regulatory reimbursement arbitrage, depending on where you go, if you have access to these different therapies, which we'll talk about in a sec. Let me go back for a sec. So it's not crazy to go across the border for drugs, pharma drugs. The state of Utah paid the state employees. They had a program where basically you could go get flown to San Diego and then shipped across the border to Tijuana to basically get drugs across the border and bring it back, and they would cover the whole thing. I was in Mexico recently, and in the airport, they actually have Ozempic pens next to the Gatorades. So, and if any of you are curious, which I obviously was, it is $500 for a pen in the airport, which is very expensive. But if you go to town, it's $300, but it might be Ozempic with a zero kind of thing. So it's not totally unnatural to kind of go across the border for drugs, right? But it's also true for surgeries, right? If any of you know somebody who has gotten a hair transplant in Turkey, they are famous for doing that. People go to Mexico for dental work, for example. It's not super uncommon. So you start comboing these things a little bit, and then suddenly you realize that actually maybe for new drugs and one-time curative therapies, this might be very important. And so today, because we are in the era of gene and cell therapies, this becomes particularly interesting and important. There is a ton of regulatory arbitrage now happening across the globe for cell and gene therapy development. So for example, in the US, in Montana, there is now a sovereign zone that basically lets you access gene and cell therapies after they pass phase 1, rather than going through all 3 phases. And you see similar versions of this in Honduras, for example, China, et cetera, where if you want access to a therapy and it is not available where you are, you can actually go somewhere else to go do that. So again, a big thing is like getting follistatin gene therapies in Honduras. Again, not my cup of tea, but if you really want to get absolutely jacked, go for it. But it's not just about the regulatory part of this. The other part of this is the reimbursement part. So for example, in Spain, a lot of the hospitals there will actually homebrew their own CAR T therapies, basically. And it is a much, much cheaper version than what you can get in the US. And so you have to remember, for curative therapies, you only have to go once. There is actually a real incentive for you to go to another country to get this done, especially if it's totally out of reach in your home country. And then you start thinking about okay, if it costs less to bring the gene and cell therapy to market because we only have to do a phase 1 trial, then you could price it lower, blah, blah, blah. So this is an area that I think is particularly interesting, especially as gene and cell therapies in the US are going through a whole reimbursement issue right now. Okay, so medical supply and pharmacy redistribution. There's a ton of waste in med supply and pharmacy. We just talked a little bit about PBMs doing 30-day refills every 20 days, right? Then they get dumped into the river, right? And the costs of these things keep going up. So now there's this whole new thing of trying to actually redistribute used medical supplies and drugs. So just to give you an illustrative example of this, in New York, during the pandemic, we ordered about $250,000 of DME items, and only about 324 of those were used. The rest stays in storage, and we have to actually maintain them. And then the number of discarded drugs from Part B is hitting $780 million in 2021. So it's not a small amount of things, basically. And so as a result, this kind of gray area has emerged where people will essentially buy the unused medications and diabetic test strips. So this is actually a sign you will see frequently in New York, is we'll buy your diabetic test strips. You'll see this also in Facebook groups where people are like, hey, does anyone have any extra Humalog? We're kind of down to our last amount. And then people will kind of just chime in and say, yeah, I got some. Which really just goes to show, if you're willing to trust this sign, you're really in a tough spot, right? And so now a bunch of companies are sort of popping up trying to provide a more accredited-ish middle ground that says hey, we'll take those things off your hand and resell it. Again, I don't know if test strips with a Z is my form of trusting stuff, but it seems to be trusted by people on Trustpilot. So there's that. A company I've invested in called MetaCircle will do this for drugs. So people with unused medications send it to their pharmacy to be recertified, and that's basically given to patients for $0 cost, and the employers pay way less than they would pay for a normal script through a PBM, basically. So there's a lot of companies basically trying to provide trust in this gray area, basically. Okay, spouses and coverage. As many of you probably know, being a part of having marital status is one of the conditions for coverage, creates some very weird ways that you can optimize your health coverage between you and your partner. And as there's a higher variance in the coverage between employers, then you have to start thinking about this more. And this is very true because healthcare is now one of the #1 costs per household. It is now higher than housing. So you will obviously, as a household, think about how you can optimize it. I got married recently, and thank you. Definitely crowning achievement of my life. But as you can imagine, as a newsletter writer, my benefits are not great. So first thing I did was obviously enroll in my wife's plan, and life got 10 times better. If only she was on a self-fund plan, or if I was on a self-fund plan, this might be very different, but here we are. So I'm on my wife's excellent Fortune 500 plan. Honestly, it's the only way that a person can go explore their passions nowadays. But anyway, it did send me down this rabbit hole of like, well, actually there's like lots of different ways you can optimize your health coverage by marital status. I'll go through a few. In Texas, the exchange plans are really bad, and they're basically all HMO plans. So if you want a PPO plan, you're kind of shit out of luck. Here's what you can do. You can have a company where one partner is the CEO and one partner is the employee, and then you can tap into small group plans, which then give you access to small group PPOs. So you can create a company with your partner. Nothing says, till death do us part like an LLC. And then you get access to PPO plans. Okay, who here has heard of ICRAs? Raise your hand. Who here has heard of QSERAs? Raise your hand. Who here has heard of CIRAs? I see, yeah. Russell, obviously. A CIRA is not to drum roll too much, a spousal incentive health reimbursement plan. This is basically a way that you can, as an employer, incentivize your employee to get on your spouse's plan and get off my books. And the way you actually do that is you say, hey, if you enroll in your spouse's plan, anytime you have to pay copays or deductibles, we'll make a little wallet for you with tax-free dollars, and we will cover your copays and deductibles. And so it basically shifts the employee off your book and onto your spouse's book. As you can imagine, this works shockingly well. In one case study I looked at, it saved $3.7 million across just 331 people. So now, again, I don't think we can all do that because someone has to have people on their plan. But if you want to get real creative, this is one way that you can do it. And then the darker version of this is the Medicaid divorce. Does anyone know what this is? I know, I heard a geez. So Medicaid divorce is if someone needs long-term care, but you make too much money to qualify for Medicaid, then you basically are paying out of pocket. What you can do is transfer all assets to one partner, get a divorce, and then basically that person will qualify for Medicaid because there's no assets in the asset test, and then Medicaid will cover their long-term care. Now, you have to have a lot of trust in your partner because you're putting all of the assets in their name. Would everyone here get a Medicaid divorce with their partner if they needed to? Don't answer that. But there are law firms that specialize in this, for what it's worth. Okay, I'll go through a couple more. I hope I haven't depressed you all or weirded you all out too much. Open source in healthcare, this is something that I think is super interesting. A lot of the standards in healthcare are very costly to use, and they're very inflexible. They're usually like maintained by one organization that kind of is like a nonprofit or doesn't really care about keeping the standards up to date. And so you're seeing this wave of open source now hit healthcare. Sorry, too far. Okay. So standards are a pretty good business, perfect. Standards are a pretty big business. In 2023, the AMA made $300 million in CPT code royalties. How many of you have paid for CPT codes? I can imagine it's quite a few of you. So they are very costly, and then also they're very inflexible. So if you've ever had to send a claim or a eligibility check through X12, for example, you will know how hindered you are from the kind of information you would like to send and get back in response. So what if we could build our own standards that everyone could contribute to, et cetera? So you see some companies doing this. So for example, a company called Brooklyn Health is using digital biomarkers that you can use in clinical trials, for example, that then are added to their sort of clinical trial software. Tuva is a company that creates an open source data ontology. So you can basically map your raw data. This kind of pre-processes it and then makes it analytics ready. So there are a lot of consulting firms that you can pay to do this, or you just use the open source model. Turquoise basically offers a open source contracting and CPT code alternative to kind of do like simple contracts essentially. And then now you see a lot of open source AI medical models that you can actually run locally on your own computer and not necessarily expose PHI, for example, to cloud-based AI companies. So you can basically just use these for free. They essentially make money in other ways, either by offering services on top, or they sell something else, which this plugs into, et cetera. But it'd be kind of nice if more things in healthcare were free. The other interesting part is that patient communities now are open sourcing stuff that they're doing. So for example, OpenAPS is a patient organization that essentially basically creates a software package that connects to a glucose monitor and insulin pump to essentially create a full loop, closed loop insulin artificial pancreas. Basically, it's called the artificial pancreas. I forgot what the S stands for. But basically, you download this Python script. It plugs into your like Dexcom suite or whatever. And then you can basically make your own artificial pancreas yourself. You also take on the risk of doing that, but that is sort of the point of this. And then last but not least, my final trend is brain wearables. This is least scientific maybe, but I don't know, I'm not the doc here. Okay, so we talked a little bit in some of the earlier talks about how mental health services, access to mental health services are getting worse. People want non-pharmacological interventions for mental health issues. And then again, like on the total other end of the spectrum, people are looking at this for performance enhancement as well. And so you see, for example, again, I probably don't need to explain this to this room. The wait lists to see a therapist are getting longer. The wait lists to the caseload per patient for these therapists is getting higher. It's getting worse. Don't need to explain that here. So what are some companies trying to do? So some companies, for example, are using ultrasound to try and target certain parts of the brain externally. Again, they are trying to do this in some performance enhancing ways, like, oh, you can focus better. And then in other ways, they're trying to treat more severe conditions like severe opioid use and things that don't really have a ton of interventions on the market today. Or there are companies that are trying to do this where the interventions have strong side effects. So some companies are trying to do this for sleep, for example. Prescription sleep medication has a lot of side effects. It can make you drowsy, there's dependency issues, all that kind of stuff. So some companies are trying to offer this for things like insomnia, for example. I think the mechanism of action here is like using sound or something. I don't remember this, but again, not the doc here. This is in that gray area of medicine situation we were talking about. And then you have, the other interesting thing about all of this is that because you kind of have this dual use, you have performance enhancement and trying to target real indications, there's a new business model, basically. So you can actually go cash pay and sell this as a subscription to people who want it for performance enhancement while you put it through trials and research to see if it'll work for more serious indications. So this is very antithetical to the way normal medical devices work, right? Most medical devices are selling straight to the hospitals, and that's basically their mode. This is kind of taking like a dual use business model. So that's the end of my talk. I want to just leave you with the question of like, what do you think is going to be weird today that might be normal tomorrow? Again, a lot of this stuff is real fringe. If you want to talk about the other even more fringe stuff, I will be at the bar later, and I'm happy to talk about it. My quick soapbox to shill stuff is that we do teach a bunch of crash courses about how healthcare works. I teach a healthcare 101 course. I'll even teach you how PBMs make money. We have a claims data course. We have a AI and healthcare course, all that kind of stuff. We do a bunch of, don't fail on me now. We do a bunch of conferences and hackathons and stuff ourselves. We have a healthcare data conference in the fall. We do hackathons where we show people how to like build cool AI stuff. So happy to chat about that if any of you want. And then, yeah, if any of you want to chat later, I'm chronically online. I'm very easy to find. Shoot me an email. You can find me online, or you can sign up for the newsletter and see all the different stuff we're doing. So yeah, hopefully this was interesting. Thanks for. I'm sorry for being between you and the bar, but hopefully this is fun enough.
Thank you, Nikhil. Here's a seat for you, sir.
Sweet. All right.
A little bit forward. All right. All right.
Do you think I weirded people out enough?
Well, judging by the Q&A, there are no questions right now. I think people are processing.
Fido up.
Yeah, we
Should we do it live?
maybe we need a couple minutes of just silent meditation after that, just to
A second beer for sure.
yeah, or that. While you're putting your questions in, I do want to just make a little bit of an announcement that the Milwaukee Brewers have just won their 12th in a row. Come on. And that means we're how many games ahead of the Cubs? It's 8. So, any Cubs fans around here? You're not going to raise your hand at this point. Okay. So put your questions into Slido. I do want to say a couple things while these are getting loaded in. And that's the fact that you talked a lot about consumerism.
Sure.
Okay? So what are we talking about at this conference? We're talking about consumerism in a employer-sponsored plan. That's essentially what we're doing. We're driving change within your employer-sponsored plan to change consumerism. Because if we could purchase healthcare the same way we purchase everything else, I don't think we'd have the problems or as much of the problems that we have now, right? And so we need the transparency, we need the data, the insights, and we need the control to be able to make those choices for ourselves. So one of the first things you said that really stuck out to me was, we do a really good job in America of thinking that there is a product that's going to solve my problem.
Yes.
Right? I mean, we just talked about the GLP-1 crisis, right? And the state of obesity in our country, and people thinking if I just inject this drug into my leg, that everything's going to be okay. I'm going to lose weight, and all my problems are going to be solved. And it is such a capitalistic issue to see a problem and then to create a product to solve that problem. That is a very American thing right there.
I think it's beautiful, personally.
And I think a lot of plan sponsors can relate, and brokers can relate, that there are like a bazillion point solutions out there. There's a point solution for every single problem in your health plan. Hey, we're having this issue in our health plan. Is there a product that you can sell me or show me that will solve this? Right? And is that healthcare? Well, I don't know. To me, healthcare is a relationship between a patient and a provider, right? So sometimes the point solutions help. Sure. Do they hurt? Yeah, they could. Are they wasting money? TBD. I think it's an interesting thought. So
I think also just to riff on this a little bit, which is one part of this is patient choice, but a part of patient choice is also letting patients choose how much risk they want to take themselves. And I think a big problem with the US healthcare system is it's very paternalistic. It does not want, it's like we will make the decisions on behalf of patients on what is like the appropriate level of risk that you're allowed to take. I think this is one of the reasons people feel very low agency and feel like things are sort of just happening to them, is because they're like, well, I didn't really make any choices here, right?
It was provided for me. It was given to me.
Exactly.
Thus, I don't have control. I can't do anything else.
Exactly.
This is the way it is.
And so interestingly, GLP-1s are a case study of actually patients actually choosing their own risk, because you can go down a whole slew of compounded routes that all have different risk profiles based on how sketchy the compounder is, or you can get the like prescribed version of Ozempic, et cetera, and you kind of choose your risk profile there. So again, in my venturing in the subreddits of our Ozempic and all this kind of stuff, a lot of people choose to go down the sketchier routes to get GLP-1s. Stuff happens to them, and they acknowledge they can only really blame themselves. And it's sad, and bad things happen, but people at least feel agency in that situation. That's like, I'm actually making the choice here of like what level of risk I would like to take as a patient.
That's interesting. The change of consumerism. Okay, here's a great question. Out of everything that you've researched and research, we'll just use that word loosely. Out of everything you've researched on subreddit, what fringe trend do you think that is weird today will be normal tomorrow? You gave us a lot of trends, micro trends. What do you think is going to be the one that takes on? Please don't say the breast milk thing.
Definitely not. Oh, God. I do think that there's a lot of screening and tests in that gray area, even like full body MRIs, for example, that I do think, for better or worse, there's just too much consumer demand to ignore, and larger lab panels, full body MRIs, all that kind of stuff will probably get pushed into more mainstream, if more so than it already has, and it'll probably come down in cost, or people will get more HSA dollars that they can spend, they'll use it there. So I think that will probably happen, and my hope is actually that the increase in consumer demand for that kind of stuff hopefully actually makes the scans better in the sense of actually like not flagging incidentalomas and causing all this downstream cascade of care that's not necessary. But hopefully if more stuff happens or people are getting it on a regular cadence, we'll discover.
So labs and images and full body MRIs.
Yeah.
Basically, we're taking the culture of me and we are applying that to healthcare, is what you're saying is going to be happening, which makes sense to me.
I mean, like the Apple Watch has a single lead ECG in it now, right? So you can only imagine that there's a world in which much smaller, more portable hardware is in way more homes.
And AI is going to just push that along more rapidly. All right, this is a fantastic question, and I'm going to plug his newsletter right after this question. What are you seeing other countries do that the US could learn from in keeping healthcare costs down, particularly given aging populations across the globe? So one of my favorite letters or issues, thank you, that he has is him talking about in India, them starting to develop a health insurance system in India, and the comparison about how it's starting there and how it started in the US and what they're doing there. And you're basically like watching the Titanic happen unfold, before your eyes, because it like started the same way here, where it's like, it's cheap and it's like good. I'm like, well, it makes sense. And it's only $5 and, and it gives me access to this doctor and whatever. And you're just like, I've seen this play out. I know what's going to happen. And it is hilarious. It's very informative. It's very good. So this is a perfect place for you to jump on that and go back to that issue. And how would you answer that question?
Yeah, I mean, just know that there's no perfect healthcare system in the world. Everyone makes a set of trade-offs. I think Singapore is probably the most interesting healthcare system because what it does is it forces basically employees and employers to allocate a portion of their income into something that effectively looks like an HSA. And then you basically have to use that for outpatient care, essentially. And then the government effectively covers inpatient care and unexpected things like cancer, all this kind of stuff. So you kind of get like an interesting blend of shoppability on the HSA side and then kind of government contracted rates on the inpatient and more catastrophic side. So that stuff I think is particularly interesting. But there's also a bunch of small stuff. For example, like expanding scope of practice seems like a no-brainer. You can point to a bunch of different countries, for example, that let pharmacists prescribe really low acuity things for like, UTIs and pink eye and all this kind of stuff, right? Like there's a lot of examples we can look to in the world and tons of data already about like expanding scope of practice beyond what we already have today.
Okay. Any actuarial data on the success of the Coursera? And the assumption is, well, this only works if the sick, right, or the unhealthy spouses are moving off the plan, right?
I assume you mean the SIRA, the like spousal incentive one. Yeah.
Spousal carve out, yeah.
I have no idea, to be honest. I did not look that deeply into it, but my guess is the way this works currently is for small groups that don't offer good coverage or any coverage at all, that have a partner with good coverage, that basically as an alternative to offering any coverage whatsoever, you're like, hey, I'll offer you this spousal incentive thing instead. Go get on your spouse's plan.
So, and the way I would answer that from a self-fund health plan perspective is that as plan sponsors, as plans, we have two levers to control costs in healthcare. That's control the cost of the actual claim, the care, right? Direct that, or control the population, which sounds
risk pool.
That sounds risk pool, and really that's it. So yeah, if people leave the plan, you're lowering your risk more than likely. And so that's the basic, framework for that. So we at Self-Fund Health are really solely focused on the claim, the quality, the care, the cost of the care, shopping for healthcare, the same way you shop for everything else. We then help and allow and assist the advisors in the spousal carve-outs, high cost claimants, stuff like that. Tomorrow we're going to dive deep into a lot of these topics. It's going to be a long day, but it'll be extremely informative. So stick around for that because we're going to have more discussions on that. Okay, I really love this. I'm going to skip down. If you could create an app, and so you need to know. So Nikhil gets pitched to. How many times do you get pitched to in a week?
Like 10.
10 times. Yep. And so if you talk to any investors in early stage startups, It's basically like a conversation wheel, and he's going to see the same idea iterated about 25 different times.
It's like Memento. You know?
Exactly.
I feel like I'm reliving the same
Exactly. So
day.
he's got some great stories about this, but so early stage founders going to come to him and pitch, hey, I have this idea for this app or this healthcare thing or this blank, fill in the blank. So flip to you now. If you could come up with any app, technology, service in healthcare that would help, what would it be? Really curious your answer.
Okay. One thing that I think is interesting is that the voice AI stuff today has gotten very good, both in terms of transcribing things people say and also robocalls out. I do encourage everyone here, if you do not already, to have a safe word for people in your family so that if someone calls impersonating you, they know that it's actually you and that's not to scare you.
Can you repeat that? That's terrifying. I don't think everybody actually heard the ramifications of that.
Me and my parents, for example, have a safe word so that...
Which is... Oh, that's right. Okay.
Got him. Just in case someone calls impersonating me. But the less dark version of that is there are a lot of times where you can call in advance to a provider and ask what the cash pay price is if you just pretend you don't have insurance. And I kind of wish that before I had anything done, a bot would just parallel call all the providers in my area.
That is such a good idea.
Ask for the cash pay price.
That is
in
such
advance,
a good idea.
Just pretend they're uninsured, and then
where's
give
John? I'm not smart enough to create that, but that is such a good idea. So
it's not super hard. If anyone wants to go do it, I'll encourage you to.
You're sitting on a unicorn, dude. What are you doing here? Go develop, vibe code that thing up. That is a great idea.
That's my app idea.
That's a great idea. Okay, we'll talk later. I'll pitch you at the bar.
Go.
Okay. How do companies stay HIPAA compliant? Do you know much about compliance?
Enough.
Okay.
Does that inspire confidence?
How do companies stay HIPAA compliant with some of the apps that break down the data? We're going to talk more about this tomorrow as well. Not the app thing, but the data thing in HIPAA. So
short
stay tuned.
version is you can sign a BAA with anyone who is handling medical data, or you can launch your app locally, basically to where the data kind of sits and not bring it into a cloud environment. There's a lot of more nuance there, but you can also de-identify the data before it hits your servers. There's like lots of ways you can do it.
So another claim question, what insights does claim data have that we're not using yet?
Ooh, great question.
So, it could be trends or it could be, here's the basic things we look at, musculoskeletal and cardiac and, oncology and whatever. What are we looking to claims data for, but that it will never actually help us with?
Well, yeah, claims data is I think that's like the reverse of the question
yes.
too. Claims data is weird, right? Because it is a derivation of the billing of it, right? So, for example, if you're not billing through claims, it won't show up. If you're getting a compounded GLP-1 through cash, it won't show up in your claims data. So there's lots of holes in claims data that don't exist.
And the ICD-10 codes are the diagnosis. The claim is what actually service was rendered. And if you want to know the relationship between the two, it's fascinating. Just throw it into ChatGPT, go down a rabbit hole.
There is a ICD-10 code for hickeys, if anyone is curious about that. So the thing with claims data that's really good is that it's very kind of widespread, right? It's relatively, I would say it's like mile long, but inch deep. And so the cool thing is that now today, the new-ish use cases are using it for like pharma use cases, for example. So understanding treatment patterns and all this kind of stuff by mining claims data across like really, really long timelines, basically. But I don't think claims data is really that interesting of a data set. The most interesting data sets are actually biobanks, and this is like the area that I think is most underutilized in healthcare. So, the UK famously has a biobank that's been going on for like 20 plus years. People are just tracking everything about their data from a healthy baseline through as they go older. The US has been trying to do this also. There's something called All of Us, which is a program that's trying to get a bunch of people to do the same. But the largest biobank we have today is actually the Veterans Affairs. So actually we have a massive amount of data from military personnel from when they start, healthy baseline, all the way through when they stay in the VA, because they usually stay in the VA system for the rest of their lives for the most part. So it's quite longitudinal. And so now you have all these really interesting papers that look at really long timeline correlations between things. So like a paper that came out 3 years ago showed the link between getting Epstein-Barr virus and multiple sclerosis much later in life.
Wow.
And you could not do that if you were not taking regular specimens from people all the time. And so that, I think, is the most underutilized, but also doesn't touch claims because the VA doesn't have to bill through a claim system, right? So actually, that's much more interesting is like the deeper level data sets that start from healthy baselines. So if any of you use a wearable, for example, you may have gotten it, like I have an Oura Ring. It's my wedding band, you can roast me for that. But it starts from a healthy baseline. So if I, for some reason, develop Parkinson's later in my life, this can maybe, hopefully, tell me when the dyskinesia started way later versus if I just go when symptoms appear, we kind of started too late, right?
Okay, so you're in Wisconsin. A lot of us are in rural areas of Wisconsin. So I'm going to pop in a little question here.
Sure.
Something that I've heard quite often about member level data. And okay, you're cool.
Thank you.
With you're cool with your data being out there,
Sure.
right? Because you want to help the greater good and everything else. But Bill from Minong, Wisconsin, is not going to be so cool with his information being out there. Am I right, everybody in the audience? Because you all have a Bill in your organization. He doesn't even have an email address. Okay, so you're not New York anymore here, Nikhil. So what do you want to say about privacy data, health data in general, claims data that maybe they don't already understand, which is that everybody knows everything.
Yeah.
And we can find it.
Yeah, I mean, I'm kind of two minds of this. Like one part of me is like, I think everyone says they really care about privacy, and then when you give them the option of convenience, they'll pick convenience over privacy every single time. Does Bill use Google? Because Bill's already made that trade-off then, right?
Good point.
So I think the reality is most
definitions
people,
define privacy. Yeah.
Well, the main issue is that most people don't feel like they get utility out of their wearable, for example. And so if there's a perceived privacy issue, it really is more to offset the fact that like maybe I'm not getting that much stuff from this thing anyway, versus Google provides me a lot of utility in exchange for my information. So it's like an easier sell. The second thing though, which I think is very top of mind right now is we're kind of at this strange time where we don't quite have like a consumer privacy framework in the U.S. that works
at the consumer level.
At a consumer level,
plan sponsors, you do.
Yeah, so we have HIPAA in healthcare, but as soon as that data exits the healthcare realm, so let's say you bring it into an app you use, or you're using ChatGPT for diagnostic reasons,
zero protection.
You have no protections, and so the issue that I'm sort of worried about a little bit more is that I don't think we don't have a great privacy regime here in the U.S. today for regular consumer stuff, and so I think there's stuff we need to think through here. California is probably the most far thinking about this with the CCPA Act that they put, and then Europe obviously has GDPR. You've probably seen the cookies all over the web now. So, but we don't have one in the US, which is kind of scary as more data comes into consumers' hands. Someone could sell you an app saying, hey, put all your health data here and we'll help diagnose you, and they just use it to sell it somewhere, and there's no actual like means of stopping that today.
All right, a couple more, and then we will wrap it up and have some fun tonight. So I think I know where this question came from, even though it's anonymous. How do you think about cash pay in general, not just for fringe treatments?
I feel like a Jonathan asked that question for sure.
Somebody over here.
I think cash pay is great. Like one of the reasons I'm here is because I'm a big proponent that consumers should be more in the shopping seat. And I think what everyone's doing here is really great. And that's kind of like what excites me. And I think the only way that we can get healthcare to be at all bending in the cost curve is by making people more aware of the prices that they're paying at the point of care itself. I think like if there was one policy I wish we could push is that like good faith estimates have to actually be a thing, and you have to be able to know at the point of care exactly how much you're paying. I think healthcare is like one of the only transactions in the US where you go and you're just like, I hope it was not $1 billion, and then you'd wait for 90 days and don't hear anything, and then 180 days later you get a bill from collections. And like, that's crazy, right? That's like an insane.
And the providers are just as confused about it. I mean, let's be real.
Totally.
I mean, they're doing the same thing. Let's apply these codes and hope we get some decent reimbursement from it, but we don't really know.
It's total nonsense.
Yeah, totally. Okay, last one. What health development, so this is now going into plan sponsorship, and again, I want to totally encourage you, sign up for his newsletter, but his courses are fantastic. They're very intensive and cooperative, and co-op, you don't have to actually go to New York to do it. Stay far, far away. No, I'm just kidding. But you can if you want, I guess. I mean, yeah.
You're welcome to come hang out with me.
But he does know a ton about employer-funded health insurance as well. He's in that world all the time. Too much, he says. So this is a question for you on that track, because we are a self-funded event here. What health developments are most important for the self-funded plan to track within their population?
I mean, this is going to sound obvious, and it's kind of been beaten with a dead horse this day, but like GLP-1s by far are going to be the most important thing over the next 5 years, because there will be a point at which the ROI becomes net positive, and it is not super clear exactly when that's going to happen. Because are rebates going to push prices down? Are we going to find out that like people got less surgeries for X, Y, and Z thing down the road? Really hard to do that. Really difficult, especially to do that in the employer side of things, because if people churn out of your risk pool, it's hard to track that longitudinally, right? And so this is going to be, I think, both the biggest issue as well as potentially biggest benefit of these drugs is reducing costs long-term for everybody. But it won't work if everyone is jumping risk pool to risk pool every single time. So I heard an interesting pitch recently. This is related to gene and cell therapies, but I think can be applied to GLP-1s also, which is basically creating what effectively looks like a carbon credit system across employers, where if employer one pays for drug X that has an ROI of whatever, then when that employee goes to the next plan, basically, the second employer pays the first employer however much the ROI was. So it works if everyone in the pool agrees, like, hey, this gene therapy is going to solve this. Let's just say it's hemophilia, right? Hemophilia can be $1 million a year.
Cure it.
You cure it, right?
Cure it. Not going to have a bleed event again.
But it's a $5 million drug. Well, employer one's going to be like, well, if I pay for this and the employee leaves, I'm like really shit out of luck, right?
It's an investment.
It's an investment. Your stop loss carrier is going to have a serious conversation with you. But if every employer in a given geography that employee is probably going to churn to agrees, hey, this is worth covering. If we pay for it, next person should give us a credit for doing so. You actually get into some interesting areas. So that could be one way.
That is very interesting. And that would take collaboration, which I feel like...
If only there was someone who could coordinate a bunch of employers
in one spot. Yeah,
exactly.
That's awesome. Hey, thank you so much for being here. Nikhil will be around for the little while. Yeah. If you want more questions, you know where to find him. Subscribe to his newsletter.